Hello, my name is Dr. Alexander Pearl, and I'm a leukemia faculty member at the Abramson Cancer Center of the University of Pennsylvania. This presentation is titled Quizartinib in the Treatment of FLT3-ITD Positive AML. To provide some background, activating mutations in the FLT3 receptor tyrosine kinase occur in approximately a third of patients, with FLT3-ITD mutations, or internal tandem duplications, being the most frequently seen, and also the ones most commonly associated with poor prognosis due to high relapse rates. For this reason, drugs targeting FLT3-ITD in terms of tyrosine kinase inhibitors have been developed. I will show on the next slide some of the drugs and their relative strengths and weaknesses. As you see, there have been several drugs developed that have been tested in the clinic, and these vary both in terms of their selectivity against FLT3, which is diagrammed by their binding against the human kinome below on these kinome scans, and also their relative potency in cellular assays, both in culture medium and in human plasma. As you can see, the top three drugs, which are relatively non-selective, are also relatively low potency in human plasma, meaning there's very little free drug present, and it's hard to actually inhibit target. By contrast, Quizartinib is the most potent FLT3 inhibitor to be developed to date, and in human plasma is able to inhibit FLT3 kinase quite potently at low nanomolar concentrations. Clinical studies of Quizartinib showed that the drug was tolerable across a wide range of doses, with the maximum dose being limited by QT prolongation on the EKG. This was generally asymptomatic and could be managed by dose interruption or dose reduction, as well as avoiding other drugs that would also prolong the QT interval. As you note, a number of drug doses were tested in patients, and response rates above the dose of 30 milligrams per day are relatively flat all the way up to 200 milligrams per day. But as you see, the toxicity of the drug is considerably higher in terms of QT prolongation above the dose of 60 milligrams per day, and therefore doses above this level are really not recommended clinically. Here we see the design of the pivotal Quantum-R study, which tested the efficacy of Quizartinib as a single agent for patients with FLT3-ITD positive AML in first relapse after a first remission of less than 6 months or who relapsed within 6 months of a transplant. As well, patients who were refractory to initial intensive induction chemotherapy were eligible for study. Patients were randomized to either single-agent Quizartinib or salvage chemotherapy of their investigator's choice, which had to be selected prior to randomization. There were three choices: low-intensity chemotherapy with low-dose Ara-C, or high-intensity chemotherapy with mitoxantrone, etoposide, cytarabine, or FLAG-IDA. Patients who responded to their assigned therapy could go on to transplant, and those in the Quizartinib arm could receive Quizartinib as maintenance following engraftment. There was no crossover from the chemotherapy arm to the Quizartinib arm for non-response, and the primary endpoint of this study was overall survival. Here we see the results of the Quantum-R study, which show higher response rates in terms of complete remissions, as well as longer durations of complete remission with Quizartinib as compared to salvage chemotherapy. The transplant rates, again, were higher in the Quizartinib arm, and all of these improvements in response also translated to an improvement in survival, with a hazard ratio of 0.76, indicating a statistically significant improvement in survival for patients treated with Quizartinib over standard chemotherapy. It's notable that the duration of responses in both arms was relatively short, so there's still a lot of room for improvement, and it's pretty clear that the best improvement that could be made would be to prevent relapse altogether, and thus, if this drug is quite active in the relapse setting, one could only imagine what it would do in the frontline setting. I should also note that Quizartinib's toxicity profile is generally pretty mild, and this drug was mostly given in the outpatient setting on this study, obviating the need for prolonged hospitalization to achieve these results. The side effects of the drug primarily are cytopenias, perhaps dysgeusia or some GI upset, and elevation of liver function tests is not uncommon. Clinically significant QT prolongation was only seen in 3% of patients on the Quizartinib arm in this study. So if we're going to test Quizartinib frontline, what are the data with other FLT3 inhibitors in this setting? Here we see the data with the multi-kinase inhibitor Midostaurin, which, as I showed previously, is a relatively weak FLT3 inhibitor that's not particularly selective for FLT3, yet improves the survival of patients with FLT3 mutations when added to frontline intensive chemotherapy with 7 and 3 and post-remission high-dose Ara-C. That benefit extends also to patients who receive transplant in first remission. Notably, while this study did include maintenance after chemotherapy, it did not include maintenance after transplant, and it's not clear that the maintenance improved survival because a post hoc analysis of maintenance-treated patients showed no difference for patients receiving midostaurin or placebo. So there is some room for improvement in patients with newly diagnosed FLT3-ITD positive AML. And given midostaurin has relatively little activity as a single agent in the relapse setting, one could reasonably figure that Quizartinib, with substantial activity in the relapse setting, could dramatically improve outcome when added to frontline 7+3, high-dose Ara-C, and/or transplant with maintenance to follow. And that's exactly the design of the Quantum First trial, which is shown on the next slide. On this study, patients receive up to 2 cycles of 7+3 chemotherapy with either Quizartinib or placebo, and then those in complete remission go on to high-dose Ara-C consolidation and maintenance. Those who go on to allotransplant can receive Quizartinib as maintenance or placebo as randomized initially. This study is already ongoing and approximately halfway enrolled. The primary endpoint is event-free survival. So what do these results mean for those treating patients with FLT3-ITD mutated AML? Well, I think Quizartinib has shown it is the first FLT3 inhibitor that can improve the survival of patients who have relapsed refractory FLT3-ITD positive AML in comparison to standard chemotherapy when used as a single agent. There is some toxicity that must be monitored because there's dose-dependent QT prolongation, but this rarely is something that limits therapy and certainly can be managed with avoidance of other QT prolonging meds or can be mitigated by dose interruption or dose reduction. This is a very high-risk population, and an improvement in survival here is really clinically important. And obviously, we would like to improve the outcome of patients from diagnosis and prevent relapse altogether, and that's exactly what a study like the Quantum First trial will hopefully show. It's notable that there are other FLT3 inhibitors in this vein, and these will be covered on other presentations in this series. Given the positive findings from the Quantum R study, we expect that Quizartinib likely will be filed for regulatory approval, and we hope that someday this will be an available therapy for AML in patients with relapsed refractory FLT3-ITD mutation. Thank you for listening to this presentation.